bachelor's levels course. So this might be a new topic for us. So the CT scan is a very vast topic. I had like 115 slides in this presentation, so I have removed so many of slides to make it short, and because if there will be more slides, there will be more confusions, and because it's a vast thing, firstly we need to know the basics of CT scan, and after that later on we can discuss many more deeper things in it. um, if we are able to know basic of interpretation of CT scan, it will be good for us. So before starting my presentation, I'll tell you how I thought to learn CT scan. So when I was in my fellowship, one of my relative came to there for regular eye examination for him, and the complaint was like proptosis of eyeball. And after that, someone has told them to do CT scan, some of the ophthalmologists. So I went there and I had done the CT scan. After that, we came back to home, and my relative asked me, uh, "See the report, how is it?" And I was totally blank because I was not taught in my bachelor level anything about CT scan. So I thought it will be normal only, no. And after that, when we went to hospital, the doctor said there is a mass behind it, and the shyness in my face was so dull. So I thought later on to learn CT scan, because it is also a part of our optometry skills. Because sometimes it helps to make the diagnosis, exact diagnosis in the case, and it also helps to make the management. Sometimes the surgical things has to be done, or sometimes wait and watch to be done. What to be done is decided by seeing the CT scans report. So let's start CT scan. So the basic principle slide so can be.
Hello, sir. Is there any problem?
Yeah, yeah, fine. So coming to the principle of CT scan. So uh, as we know, the CT scan full form is computed tomography. So tomography is a term generally comes in our so many field, like sometimes OCT, sometimes B scan. So in that always the ways where the ways things comes, their tomography works. So the full form of CT scan is computed tomography scan. So computed tomography is based on the degree of attenuation of X-rays passing through the tissue with different density in the body. So when we explain attenuation means the reduction of the force. So anything if passes in the air, it goes with the great speed. But sometimes when any obstruction comes there, so the speed of speed of that thing reduces. So in the same way, when the X-ray passes through the body, so if there is any obstruction, any mass or anything, there will be the reduction in the force of that X-ray. So that reduction is calculated uh, in these scans, and according to that, the diagnosis is made. So the attenuation is the reduction of the force. So in the same principle, this computed tomography acts. So the degree of attenuation will depend upon the energy of photon. So how much dense is the mass, how much dense is the tissue, or how much dense is the bone or anything, that the degree of attenuation depends upon that one. If the mass is thinner, so the X-ray will pass, the speed of attenuation will be faster. If it is dense, the attenuation will be little slower. So these differential density are used to characterize the tissue, which type of tissue or which type of mass is there. According to that attenuation only the CT scan calculate. So coming towards this picture, so in this picture, if you see, so this is the rotating X-ray tube. So when the patients lay down on the bed, and that bed comes inside this rotating wheel scan. So this This is the beam where the X-ray comes, and these beams rotate like a fan. From the every from the 360 degree scan is from 360 degree the X-rays passes and the scans are taken. So these scans are detected by these ring fixed detectors. So these detectors this calculate the attenuation of the rays, and this will be sent to the computer. So it is a computed tomography, the full form of CT scan. So I think this principle is seems so simple, but there are different things act in it. But in a simple term, this is the X-ray beam, and this rotates in a 360 degree, and from 360 degree the X-ray passes through this orbit, and uh, this orbit the attenuation calculated by this fixed detector, and this will be sent to the computer. So what is the advantage? Why we should do CT scan orbit? So it allows us to find the location, extent, and configuration of the lesion, its effect on the adjacent structure. Well, either the mass or anything is located in a single things, or the adjacent structures are also involved in it, and the exact location, the size, which type of configuration, shape, everything is calculated by the is measured by the CT scan. It allows us to comment on the possible tissue mass composition. It also tells us either the mass is cystic mass or it is a solid mass. So which type of mass, also the features of mass is also explained in this CT scan report. So in addition, it also tells us measures us the size of the mass. Sometimes it also helps after surgical thing, after surgery, when we remove the mass, the total mass is removed or not, or any component of mass is left. So these all are the advantages of CT scan. Mm, so coming towards the view, so there are two pictures. So uh, in this picture we can see the coronal, axial, and sagittal. So in a simpler term, there is three types of views, three types of scans generally taken in the CT scan. So first picture, if we see, this is the axial scan. So axial scan, so the axial scan is axial scan is taken from down to up, or up to down. If we see this beam, so this beam from upward to downward, from this apex to upward. So this is the things in the axial scan. So this axial is A. So A, if you see in this scan, this is the axial scan of the CT scan. Coming to the coronal view. So coronal is like anterior to posterior. From the anterior portion to posterior portion, the rays, beam of rays passes. So it takes in the B. This is the coronal scan. And third one is the sagittal, this one, sagittal view. So that is the C. In sagittal view, what happens? Uh, the uh, the CT scan machine divides our head into two parts, and after that image is taken from two images taken, and the two images will be imposed in a single image to give a 3D view of a image. So that is the sagittal view. So there are three views: coronal, axial, and sagittal. This is very important to understand that, so that in further scans we can easily understand which is it a normal scan, or is it a uh, what type of mass, or what is the irregularity in the scan. So any doubts in these views? This is very important. There are three types of views in the scan: coronal, axial, and sagittal. Any queries, we can explain it here only. So fine. So let's go towards the other slide. That is the indications of CT scan.
So may I interrupt you? Okay.
Yeah.
ओके आज चाहिँ नेपालमा पनि क्वेसन सोध्नु हुन्छ हाम्रो प्रायः सो सेसनहरु चाहिँ एकदमै इम्प्याक्टिभ एकदमै कम भएको छ स्टुडेन्टहरु हुनुहुन्छ भने चाहिँ सकेसम्म नेपालीमा पनि सर नेपालीमा पनि आन्सर गर्नुलाई सर
हो ल हुन्छ म नेपाली स्पिकर भएकोले नै सो हामी नेपालीमा पनि कुरा गर्न सकिन्छौँ
यस राइट सर ओके
सो यो स्क्यान्सको यो भ्यूज बुझ्न एकदम इम्पोर्टेन्ट छ है यसमा केही डाउट छ भने अहिले नै क्लियर गरौँ ल ठीक छ सो सो इन्डिकेसन्स फर सिटी स्क्यान इन्डिकेसन्स मिन्स के पर्पसमा हामीले सिटी स्क्यान्स गराउन सकिन्छौँ सो इन विच केसेस वी शुड सेन्ड फर सिटी स्क्यान सो द्याट इज orbital trauma so like any patient with accident or any traumatic injury in that cases to rule out any fractures we can send for the orbital for the CT scan so orbital infection like orbital cellulitis something endophthalmitis so in that cases also we can send for generally for orbital cellulitis we can send for CT scan so orbital foreign body if a foreign body penetrates our eyes and it goes in the orbit so in that cases B scan only will not help to rule out where the exact location and the exact size of the foreign body. So in that cases, we can send for CT scans. So calcification or ultrasound. So in B scan, if we see there is calcification, generally in case of retinoblastoma, where there or any melanoma or any eye cancer, you can see the calcification uh, uh, in the vitreous and in the posterior surface. So in that cases also we should to rule out any malignancy we can send for CT scan. So orbital masses. So orbital mass cannot be ruled out by the B scan. So in that cases we can send it for CT scan. Intraocular tumor with proptosis. So any proptosis, we should find out the reason why the proptosis is there. So proptosis means the bulging of eyeballs. Why the bulging of eyeball is there? So in that cases we can send for CT scan. So lesion involving the bony orbit. So any lesion involving the bony orbit. So in that cases unexplained proptosis or ophthalmoplegia or ptosis. So proptosis or ptosis which is not like according to your clinical evaluation it doesn't match. Ptosis simple, it is not a simple ptosis. Sometimes you feel that it's not be there but it is there. So in that cases if you are confused, in that cases we can send for CT. Yeah. So orbital sign with paranasal sinus disease. In the sinus, if there is mass or your nasal nasolacrimal things is pulsed, in that cases we can send it for CT scan. Unexplained afferent dysfunction, ocular surface lead tumors or in the orbital spread. So in the lead tumor, only if it is a lead tumor, the CT scan will not help. But if the lead tumor there is the spreading in the orbital area, so any tumor will be spreading, like malignant tumors will be spreading. So in that cases, so where the extent of tumor to find the exact location of the tumor we can do the CT scan. Intraocular tumor with proptosis. So intraocular tumors in that cases also we can send for CT scan. So there are many more other indications where we can send for CT scan, but this is the few important ones where we can send it for CT scan to rule out the exact location. So ordering a scan. So while ordering the scan, what we should look is we should write in all the cases we should not send for CT scan where the uh, your clinical evaluation doesn't so much clear or you are confused with the diagnosis. In that cases you can send for CT scan and a radio to where the portion of exact where the report you want, like you feel like it is a proptosis. So proptosis, how proptosis can be happen in posterior surface. So if in the posterior orbital things any mass is there, it will send for proptosis. So you can write it there, your clinical evaluation, so that it will help your radiologist to guide where exactly the scan has to be done, because the orbit is a huge thing and where the minor details can be missed. So if you write the minor things where the scan has to be taken, so that will help a radiologist to do at the exact place. So uh, helps in the manipulation. So sometimes your clinical diagnosis doesn't match with other ophthalmologist or other practitioner who have already done. So in that cases, it can the ordering CT scan can be beneficial. So scan informations. So these are the few things where uh, we can the basic things we need to understand about the scan. So slice thickness imaging plan.
Hello, sir. May I
Hazir,
interrupt you, sir? Sir,
yes, yes.
there is someone calling for there is unclarity on the voice. Can you use your headset, sir?
Yeah, I'm using my headset one. There ego.
Yeah, I don't know. There is some disturbance or cracking or lagging in voice.
Now it is clear.
Yes, sir. We can try, sir.
Okay,
Okay,
so
you can proceed, sir.
uh, uh, are you clear, sir?
Uh,
Hello.
Hazur, sir. I'll clear, sir.
And not so. These are the thing scan information which we need to know. That is the slice thickness, imaging plan, tissue window, contrast enhancement, and health cell class. So these all things I'll be explaining for the slide. So coming toward the slice thickness, what is slice thickness? If we see the scan here, the picture here, so you see the lining, right? So there will be the thousands of like this scan rays, X-rays passing through the orbit. So the distance between these two line, okay, so these two line tells us about the slice thickness. So this is called as slice. So the difference between these two line is called as slice thickness. So how much thickness you want? If you want a very minor detail, your thickness should be less. If your mass is bigger, and if you want the measurement, then the slice thickness should be more, so that the more area can be involved. So if your slice thickness is thinner, there will be higher resolution, because if you pass a torchlight through a glass, the rays will pass more. From a wooden door or wooden window, the light will not pass. So same way, the thickness, how much thickness, if your slice thickness is less, the resolution will be more. If your slice thickness is more, the resolution will be less. So it depends upon the clinical evaluation, which type, how much thickness you want. So imaging plane. So imaging plane, I have already discussed about the axial, coronal, and sagittal view. So in axial, coronal, and sagittal, so this all scan itself has different different characters. So by seeing only one scan, we should not make the diagnosis. All three scans has to be seen. If sometimes in one scan, uh, one mass is visible, in other two scans it is not visible. So we should not be making the final diagnosis by seeing only one scan. So all these three scans has to be seen. So so axial cuts commonly extend from the maxillary area to beyond the orbital roof. From down to off is the axial scan, and depends upon the pathology of the clinical evaluation. So generally, axial scan is so much important to see in the orbit thing, and order the coronal and sagittal is not so much used in our generally in eye purposes, but in other, like in your stomach or in your legs, in that cases the other scans will be important. So coming to the tissue window. So tissue window is the other things which we need to understand. So the human eye cannot see, cannot distinguish 2000 differences. So there will be multiple, I have said there will be multiple X-rays passing through the orbit in the CT scan. So all the rays cannot be identified by human eye. So what happens, the in the tissue window, if you see this bone area and this bone area, ethmoidal bone. So in that, how much this line, if you see, so the distance between these two line is called as the tissue window. So this you can increase, this you can decrease. So uh, how much bigger the tissue window, that much more visual field, the area of field can be seen. If you decrease the tissue window, uh, the area of field will be decreased. So it again depends upon case by case which type of window, how much window, tissue window you want. So if there is an orbital fracture things, so in orbital fracture thing, more bony area has to be seen, so more tissue window has to be increased. But in the cases of any tumors in the eye, in that cases, if your tissue window is less, then also it will be okay to diagnose. So nowadays the scans has been more advanced, so it is called as dynamic imaging. So in dynamic imaging, what advancement has gone? So contrast has come. So sometimes your mass and like your other like your vitreous things and the mass, so the color of the mass and this thing is same. So if you are not able to distinguish between how exact location and exact area of your tumor, so in that cases you can increase the contrast. So contrast, what will happen in contrast, so the bony areas, your orbital area will be enhanced. So the enhanced area, if your orbital things will be enhanced, you can easily identify the location of your exact location of your tumor. So this is done in the special cases. Again, the Valsalva, the spelling mistakes, L has been mistake. This is Valsalva. So in Valsalva, what happens? We tell the patient to close the nose and mouth and blow air. So in that cases, what happens? The air doesn't go anywhere, and the any in that special cases, in the pseudo tumors, in that cases, this Valsalva helps. So we close the mouth and nose and tell the patient to blow air, and after that the scan is taken. So muscles contraction. So tell the patient to stop the breathing for a few minutes, and after that when you feel the muscles contraction, in that cases the scans is done. So these are the few scans which is done in the special cases. So contrast, what is the use of contrast? Several tissue through the different though the different attenuation to the photon. So as I have told you, if you are not able to diagnose your exact locations, in that cases the contrast enhancing can be done. So how to enhance the contrast? That is the Hausen field value. So HU value is the unit which is uh, in which the X-rays are being measured. So in that case, you need to increase the HU value so that the contrast can be enhanced. So indications of contrast is the extraorbital extension of orbital tumor, vascular lesion, cystic lesion, optic nerve lesion, trauma with suspected lesion, and radiologist disaggregation. So in sometimes the radiologists are also confused to diagnose. In that cases, the contrast will be helpful. So Valsalva, I have told you. So we tell the patient to close the nose and mouth and blow air, and after that the scan is taken. So generally in pseudotumor or vascular lesions, where the vascular lesions inside the vessels can be diagnosed through the Valsalva. So while now coming towards the interpretation, while interpretation the scan, basic data has to be shown. Sometimes the report are exchanged while doing the scan. So first, if you have CT scan report, first see for the name, age, and center, so that the same report of the same patient is there or not. So first that has to be seen, and after that date of the scan is done at the same date, or this is the old report, so that can be seen. So type of either it is a plain or contrast, that has to be seen, because contrast again you have to very more if you can be confused if you think that contrast is a plain thing, that will lead to the wrong diagnosis. Again, the laterality, which eye, left eye, right eye, that has to be seen. So while starting for seeing the report, basic data has to be seen so that it is of the correct patient or not has to be seen. So now this was the about the basic things of the CT scan. I think this was little bit boring. Now we will go to the cases. So these cases we can see. Uh, this will be a little bit interesting, and this will make us understand about the different disease cases. So before going towards the disease, we need to understand the anatomy. So this is the normal CT scan. So this is the coronal view of the CT scan. So in these cases, this is the from 1 to 12. If you see the first one is the optic nerve. So this the central portion. So this identify the optic nerve. The second one is the ophthalmic artery. So the small portion or the white portion seems as the ophthalmic artery. So three is the superior rectus. So this 1, 2, 3, 4. So this 4 is the rectus muscles. One, two, three, four. These four are the rectus muscles, and this is the central portion is the optic nerve. So superior, inferior, medial, and lateral rectus. So these all four are the four rectus muscles, and the ethmoid and maxillary sinus. So
can you please zoom it out into
zoom?
Yes, sir. Can be zoomed. So in double click, it will be zoomed. If there is a problem, no problem, sir.
Is it visible?
Yes, sir.
Okay. So these four are the rectus muscles, and this is the optic nerve over there, and these are the two sinus. This one and this one is the two sinus, and this in between is the nasolacrimal duct. So nasal septum will be there. Again, in the other, this is the other. This is the axial cut. So that was the coronal cut, and this is the axial cut. So there is difference between these two. But again, you can see the first. So this is our eyeball. Okay. So this round one is our eyeball, and the white, this the circular thing is the sclera. Okay, the fourth, if you see the fourth one, so this is the sclera, the the whole round one, and this is our eyeball, and this the gray portion is the vitreous body inside the eye. So and this one sixth one is the optic nerve. This is the optic nerve in the axial cord. So this is the both eyes. So this is the axial. This is the optic nerve over there. These are the two rectus muscles. This is the medial rectus. This is the lateral rectus. 7 and 8. So this is medial rectus. This is lateral rectus. And this is the superior orbital fissure. So fissure means the small gap. So here the optic nerve passes through. So this is called as the superior orbital fissure. And the ethmoid and sphenoid sinus is not so much visible in the actually in the coronal cut. More the sinuses are visible, and this is the pituitary gland below. So this is the normal scan. Okay, now in different cases, different abnormal cases, how it looks like, I'll show you. So now coming towards the systemic anatomical evaluation. So what things has to be seen? So bony orbit, globe, optic nerve, extraocular muscles, extraconal tissue, and orbital fat. So these are the parts of orbit which has to be seen while seeing CT scan report. So bony orbit. So in bony orbit, I have told you it is generally for the bone, depends upon the bone window. So how? So if you see, this is the normal regular bone area. So this the in the enhanced part is the bony area. So all these are the four bones. So in this area, you can see this damage here over here. So this is the fracture. So this is the fracture part. So are you able to see the difference between these two eyes? So this is the regular, and this, if you see, there is a damage. So this is the orbital fracture. So the, in this way, you need to differentiate between the other eye. So many of the times, if sometimes the artifact or sometimes the images are not so clear, in that case, what you can do, you can always compare with the other normal eye. So if the patient is complaining, if there is swelling, redness, and you cannot clinically evaluate the, you cannot feel the bone with the fingers. In that cases, you can compare with this. So there is the orbital. This is the fractures or orbital bone fractures over there. Again, if you see here, and this is the coronal cuts. That was the axial cut. So in this coronal cut, you can see easily there is the orbital fractures. So this is the orbital fracture. Again, there is other multiple fracture. How you see this one? This is the regular bony area, and here you can see the exact fracture. So this is the orbital bone fracture. So if you compare the rectus muscles over here, this is the regular size of the rectus muscles. This can be measured. But here you can see, due to the fractures, these muscles are also swelling. So if you clinically see, there should be pain while opening mouth. There might be swelling temporarily near your ear, temporal side of the things, and the extraocular movement will also be restricted in this case. So always your report has to be matched with your clinical evaluation. So this is the difference in how you need to see the reports of the patient. You always need to compare with the other normal eye. If both eyes are involved, so you can compare in the parts. Suppose in this area, if the frontal has been damaged, then this area is normal. So in that cases, you should compare with the other normal parts of the body. So the fractures is easily visible. So now the other picture. So now this is the other eye. So if you see, this is the regular bony area, and you can see there is the fracture area. So this is the RTA accident cases. So there is the multiple fractures. So in this way, the bony area has to be identified. So this enhanced area, all enhanced area are the bony, the hard surfaces. So if there is any distinguishing between the two surfaces, so that you need to think that this is the fractures over in the bone. So now coming to us the bony erosion. So what happens? So this is the normal axial cut of the CT scan orbit. So this is the normal eye. So you see, this is the optic nerve, this is the rectus muscles, and this is the eyeball, right? But in this eye, where you can see this is the mass. So again, this mass, which type of mass is there, that need to be compared with your CSF. So if you this and this area is same, that means this is a solid mass, because the solid fat area will be there. But here this is more darker. More darker means this is the cystic area. Cystic, like water like thing is there. So this is the cystic area. So this is the cystic mass. So this mass, what it has done, it has pressed the bone, and the few surfaces of the bony area has been eroded. So it is called as bony erosion. So if the mass is sitting in the bone, so this has depressed, and few bony erosions has been made. So in this way, your bony area has to be, the bone parts has to be seen. Okay, so now coming to us the globe. So in globe, what has to be seen? Lens, vitreous, aqueous, and sclera can be identified in the CT scan report. So generally, if your something like for a small foreign body or any inflammation in the eye, so that can be easily done by your B scan. But the large mass, and you need to remove the mass, so exact location, exact measurement if you want, and that cases in the globe area the CT scan will be fruitful. So in globe, if you see, this is the choroidal melanoma. So this is the normal eye. If you see, this is the normal eye, and this is the sclera. But if you see in the other eye, you see the mass. So this is inside the eyeball. The mass is inside the eyeball, and it is near the sclera and totally retina. So sclera, retina, and choroid is the complex. So this is the mass is sitting over there. So according to your clinical evaluation and this one, so this is diagnosed as the choroidal melanoma. So this is the sagittal view. In that view also you can see the exact location and exact till where the extension of the mass is there. So this is the choroidal melanoma picture. Again, in these cases, if you see, the, this is the normal eyeball, and this is the with the mass. So this mass is not well identified. This is the like irregular mass, well ill-defined mass. So exact location and exact size of the mass cannot be seen in these cases. So this is the normal eyeball, and this is the mass. So this all white areas, if you see, so always you need to compare this mass with the CSF CSF thing. So this and this, so the intensity of this is almost like near about similar. So this is a solid mass. If it is more darker, then that will be like a cystic mass. So in this eye, if you see, this is a regular eyeball, but here the white intense area, so it is similar to your bone. So how much hard is the mass, you can compare with. If it is like this, if your intensity of the mass is like this, means this is a regular solid mass, like regular mass. If it is a black one, so that will be cystic mass. If it is compared to the bone, so if it is like this enhanced, so means this is a very hard mass, hard calcified mass. So this is the case of retinoblastoma. If you see, the choroid portion is not so much involved. So in choroidal melanoma, the every till sclera it was extended, but this is from, if you see the retinal portion, it has been extended. So this is the retinoblastoma case. So and this is the extension of the mass. So while doing operation, if it is not involved in the posterior surface, so the simple ma- uh, mass uh, mass can be removed. But when there is extension, the total eyeball has to be removed, which is called as enucleation. So this is the small mass. So the mass excision itself can help in this case. But if it is extended towards the orbit, towards 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 the bone, and if it is spreaded all over there, so total enucleation has to be done. So in this way you can compare for the globe. So the previous one was the bone, and this is for the globe. So in globe, if there is any mass, so in this way you can see. So now coming towards the optic nerve. So in optic nerve, what things you can see? The displacement, the crowding of the apex, the fusiform enlargement, the tram-tack appearance, and the relation to the posterior mass. So coming towards the first, displacement. So if you see, this is the normal CT scan, and this is the mass over there. So this mass, this is the optic nerve. So what has done? This mass has displaced the optic nerve. So this is called as the optic nerve displacement. Exactly, this optic nerve has to become like this centrally, but due to this mass has pressed the optic nerve and displaced from the normal position. So this is called as the displacement. So all this, how much displacement is there, that also can be measured. How much size of the, like this is the 9 mm mass, and due to 9 mm total 21.2 mm of displacement from there to there has been, the optic nerve is displaced from 21.2 mm. So in this way optic nerve displacement can be seen. So crowding of the apex. If you see the exact, the all four rectus muscles and optic nerve can be identified. But due to the mass, ill-defined mass, total crowding, I think. If you see in the crowded one, if there are like four people, you can easily identify one or two people from a four people mass. But if the mass is so much crowded, and if you want to identify someone, it will be difficult. So it is an ill-defined mass, and due to it is called as the crowding of the apex. Now this is the four image. The first one is the fusiform of the optic nerve. Fusiform meaning is tapering from the both side. Both side mouth is tapered. Okay. Both side this and this is narrowing. So this is called as the fusiform of the uh, optic nerve. So it explains that the spread has been in the optic nerve also. The optic nerve is also involved in this case. So this is called as the fusiform of the optic nerve. Now this is the tram track. Tram track means like railway track. Tram is there in Kolkata. So from the same way, the tram track. If you see, the optic nerve has to be straight, but it is like in the snake pattern. So this is called as the tram track optic nerve appearance. And these two pictures, always if there is any mass, then always the mass has to be compared from a CSF. So how much dense is the mass can be compared. If it is a black mass, it will be cystic. If it is similar to this is a regular mass. But if it is enhanced with the bone area, so this is the very hard mass. So according to that, the optic nerve involvement and the mass, how is the mass location, the size of the mass and the features of the mass can be seen. So coming to us, the extraocular muscles involvement. So till now, any confusion or anything has been asked? I think this is not so much interactive session. Any question till now?
Yes, sir. I guess we have one question there. So Gautam asking about what should be considered clinical in various scan of CT on coronal axial or sagittal.
Sorry, the voice is not clear. What?
What should be considered while doing the CT, sir? On different
What should be considered?
Yes,
what
sir.
should be considered, right? So
yes.
yeah. So as in the B scan also, B scan, many of the times we do B scan, right? So why we should do CT scan, not doing the B scan? Why we should do the CT scan, right? So in the B scan, what is the extent of B scan? Total eyeball, if there is any inflammation, if there is any foreign body, the eyeball area can be captured from the B scan, right? But if something is beyond your eyeball, right? So if there is something beyond your eyeball, beyond like in the orbit, in the orbital mass, or in the optic nerve thing, so in that cases only B scan will not help, right? So in that cases the CT scan has to be done. So the other main role of the CT scan is while doing the surgery, right? So if you want to remove the mass, right, so you need to have the measurement of the mass. How much big is the mass, till where the extension of the mass is there, so that it will help you to remove the mass easily. So in that cases the CT scan has a role over the B scan. Am I able to give your answer?
Yes, it was pretty much good, sir. There is also another question. One of the model asking about which generation of CT is best for ophthalmology.
Yes, Kapil, once again.
Which generation of CT scan is good for ophthalmology?
Yes. So so in the different generation, what is the main thing I have seen in the orbit is the clarity of the scan. So before we were not able to, as I have explained in the previous slide about the tissue window, about the size of the scan, 2 mm, 3 mm size, right? So that was not in the previous ancient scan. So nowadays, while in the advancement in the CT scan, so there are multiple advancement as the contrast, as the total size, the location, the displacement of the optic nerve, everything can be measured. So if you want, like if you are in a not so much developed area and there is a simple CT scan, and from that also you can do the diagnosis. But if you want the advancement in your result, if you want the total location has to be measured, and total size where the till the extension is there, and the clarity, always the clarity in the image. So these things comes in the advancement in the CT scan. So in the all the advanced CT scans, if you see, so these things will be different from your old CT scans. So there are different types of CT scans machine, but if you write your which type of report you want, and the radiologist sent you the same report, so that doesn't matter how much from which CT scan machines you do. So totally depends upon your uh, which area you want. So your clinical evaluation first has to be done. If it is a proptosis case, generally you want the posterior surface to be highlighted, right? If it is your like anterior, if you see the eyelid tumor is there, so the anterior-posterior parts has to be highlighted. If you're like it is a fracture cases, the bony area has to be highlighted. So in that cases, if you write a proper area which has to be highlighted, so that will not make so much of differentiate in the generations of CT scan. So Kapil, any more questions?
Yes, sir. We complete all the questions.
Okay, so later on in the last, at the last also we can have some more
Yes, sir.
discussions. So okay, so let's go towards the further slides. So coming to us the EOM. So EOM is extraocular movement involvement. So uh, if your extraocular muscles has been involved, so in that cases, what has to be seen? So in your extraocular muscles, the enlargement of muscles is there or not has to be seen. The displacement of the muscles is there or not has to be seen. Infiltration means the spreading of the tumor is there in the extraocular muscles or not has to be seen. Entrapment means if the muscles is totally hanged over with a mass has totally suppressed the muscles and it is not able to move totally. So in that cases, the entrapment is there or not has to be seen. So in the EOM part, this four thing is has to be seen. So so this is the case of Graves' eye disease, thyroid eye disease, Graves' ophthalmopathy. So if you see, you have seen the normal scans of CT scans. So this, if you see the size of the muscles, you see it is totally enlarged. This size and this size, if you see inferior rectus, sorry, superior rectus and inferior rectus, medial rectus and lateral rectus. If you see the size of difference, the lateral rectus seems normal, but the medial rectus size is enlarged. The inferior, the maximum enlargement is in the inferior rectus, and superior rectus is also enlarged. So if you do the extraocular movement of the of this patient, then while patient will look downward, there are too much of restrictions. While looking medially and superiorly, there will be mild restrictions, and while seeing the laterally, there will be very less restrictions. So in this way, you need to clinically see. So in thyroid eye disease, what are the main symptoms is the enlargement of the muscles, and in thyroid eye disease, the CT scan is not so much needed, only in the case where the optic nerve is involved or not. So if you see this rectus muscles, till now it has not touched the optic nerve, right? While towards the apex slightly it has touched, but there is no displacement of the optic nerve. So so are the rectus muscles suppressing the optic nerve, or optic nerve has been involved or not? In that cases only, this CT scan help in thyroid eye disease cases. So this is the sagittal view. Also you can see the optic nerve is totally passing away. There is enlargement in the muscle size, but the optic nerve is not involved. So now till now, if you do the color vision, if you do the uh, visual involvement, so in that cases the vision will not be so much decreased, the color vision will be fine. So in thyroid eye disease we need to see for this optic nerve is involved or not. Okay, so lacrimal gland tumor. So you see the size of the muscles is fine. In thyroid eye disease it was enlarged, right? So if you see, these are the four rectus muscle and this is the optic nerve, so it is fine. But you see this mass, is coming over there. So which type of mass is this? If you compare from the CSF, so this is similar to this. So this is a regular mass, not so much hard. If it is enhanced like this bony area, so this will be the hard mass. So this is the regular mass, and if it is black like this, so this will be the cystic mass. So this is the regular mass over there. So this is a lacrimal gland. So lacrimal gland is located here supratemporally. So this mass is arising from the lacrimal gland. So this is a lacrimal gland tumor. So while evaluating a mass, what has to be seen? So while evaluating a mass, size of the mass has to be seen, shape of the, it is well defined or ill defined, location, where it is located, laterality, which eye is involved, density, how much dense is the mass, is it harder, softer, again the contrast enhancement of the image is there or not. In the contrast enhancement in very hard mass, if it is similar to the like bony hard mass is there, then you will not be able to differentiate between the bone and that mass. So in that case the contrast enhancement has to be done. So homogeneous or heterogeneous, solid or cystic, and displacement. So all these things, I'll be showing in this image. So size, how to know the size? So if you see this mass, a big mass over there, so this red line is measuring from anterior to horizontal measurement of this mass. So in this way, if you there in report you will get the total measurement of the mass. So this mass measurement can be seen, size of the mass, how much bigger is that. Again the shape, is it well defined or ill defined? What's the difference between well defined or ill defined? Well defined means if you see the total edges, the edges are well visible, so this is well defined mark. You can able to define, you can able to see till the extension of the mass. But here in the second picture, this is the normal image. So this is the normal image and this is the abnormal. So there is the mass, but can you identify the location? This is the regular spread, till here the spread is there, so you cannot able to measure the total size of the mass. So this is the ill defined, this is the well defined. So this is the defined. Well defined means total extension can be seen, but in ill defined the extension cannot be seen. The location, the location of the mass, where the mass is located, either it is a intraconal mass or extraconal mass. Intraconal means it is in the beyond the two rectus muscles. Okay, so if it is in the cone of this orbit, so this is called an intraconal. But if it is coming to us the outside also, if you see the spread of this mass, the mass is till here, it has been spreaded, so this is called as the extraconal mass. So the location can be seen. Laterality, which eye, either it is a right eye or it is a left eye, so which eye is there, that has to be seen. Density, can always be compared with the CSF. This is similar to the regular mass, right? But in this area, the third picture, if you see, this is the black portion, right? And if you compare from the CSF, this is the cystic mass. So this mass, the picture 3 and picture 1, if you see, this is the regular mass, while comparing from the CSF. But if you see this one, if you compare, this is more blacker. This is more black area. So this is a cystic mass. Again, coming to us the homogeneous and heterogeneous. Homogeneous means all over the mass, the area is the mass is same. Homogeneous means regular mass. But if you see the third picture, heterogeneous means few area is little bit harder and other area are cystic. So this is a heterogeneous mass. There are two components. It is not a regular mass. So homogeneous and heterogeneous, we need to understand. Homogeneous means it is a regular mass, but heterogeneous means there will be the mixed component. There will be cystic mass also, and there will be regular mass also. So this is the mixed component of mass. Either it is a solid or cystic. Solid or cystic means it is like a cystic mass. It is a solid mass. And displacement. The displacement of the optic nerve is there or not, that can be seen while evaluating a mass lesion. So while evaluating a mass, this all thing has to be keep in mind. So coming to the extraconal mass and intraconal mass. So there are two things, extraconal and intraconal. So if you see this picture, so this is an intraconal mass. If you see the rectus muscles are visible this side it's not well visible, but it is inside the cone, it is inside the two orbits. So this is called as extraconal mass. But whereas if you see this one, this mass has extended till here. It has come towards the sinuses parts also. So this is a extraconal mass. It has come out, it is spread out of the cone also. So there is two difference. Intraconal, it will be inside the cone of the eyeball. So it is called as intraconal mass. But whereas if the mass has been extended towards the cone of the eye and extent of the eye orbit, so this is called as the extraconal mass. So what is the main difference clinically? What difference if you see? If it is a intraconal mass, the proptosis will be, if you see the eyeball, the proptosis, if you see the blue line, this is cutting the midline of the other eye, but here it is this much proptosis is there in this eye. So this will be the axial proptosis. Axial proptosis means the eyeball will be protruded straight, so a straight protrusion of the eyeball will be there. But whereas in this, if you see, this eyeball is protruded towards the nasally, because the more of the mass is towards the temporal portion, so the eyeball is proptosing nasally. So this will be the abaxial proptosis. So there will be two proptosis, axial and abaxial. Abaxial means like slightly deviated, not totally straight. Axial means towards your straight, total towards your parallel axis. So if the proptosis is straight, so that will be called as axial proptosis. And if it is like a little bit deviated nasally, temporally, or inferiorly, or inferior or superiorly, so that will be called as abaxial proptosis. So if it is an intraconal mass, there will be axial proptosis. If it is an extraconal mass, there will be abaxial proptosis. So coming to us, this, if you see this picture, if you see the clinical evaluation by doing the B scan, will you able to identify what is this? No. So in these cases, the CT scan helps. If you see the total extension of the mass, total regular mass is there, right? So you can measure this mass. This type of mass is this. If you compare from a CSF, if you see this is black one, so this is a cystic mass. So it is diagnosed as a dermoid cyst. So this can, while seeing, this is not a malignant, this is not a tumor, this is the benign. So there will be two types of tumor, benign and malignant. So this is non-spreading type of tumor. So in these cases, cosmetically it can be removed. So while removing, the surgeon needs this scan, so that what is the extension of the tumor can be seen and can be removed easily. So these are the different cases of while doing the CT scan orbit. So this is a very vast topic. There are multiple cases. Many more things has to be taken care while interpreting the CT scan orbit reports. So this was the more simpler forms. So thank you. So any questions can be taken. I think these were not so much interacting sessions. This might be new for many of us, but this is also a part of our eye. In any times in your life you can get this, because I have told you my story how I have learned about CT scan, right? Because it is not being taught till our bachelor's. I think in master is there or not, I don't know, but this is also a part of our eye, so we need to learn this. So any more questions can be, I'm happy to take.
Okay, okay, sir. There is one question asked by Solu Gautam. How to measure the actual size?
Yeah, so that size is measured by the machine only. So as I have told you, the computed tomography, right? So if you see the image of the CT scan, so this ring size detector is there, right? So this detector work is to measure the extension, and this rays, how the rays passes through, right? So this X-rays while passing through the orbit, and this fixed detector. So these two help us automatically to measure the size. So in your computer, automatically while doing CT scan orbit, you can easily nowadays it is an automated machine, so automatically you will get the size. If you write that if you want this things to be measured, so automatically you can get the size. But and while in the ancient time, uh, you need to mark the margin with your hand manually, and after that while marking manually, the size can be measured. So nowadays nothing has to be done, just do the CT scan, and while putting the in your software which area length you want, that can be given by your by your CT scan machine only. So any more questions?
Yes, sir. Yes, sir. There is another question. What is the difference between the CT and MRI for the
Yes,
observation?
yes.
Yes.
A Kapil, not clear.
What is
Once
the
again.
okay? What is the difference between the CT scan and MRI to optometrist for clinical evaluation to optometrist?
Again, I'm not able to understand your voice. There is so much echo.
Okay, sir. What is the difference between the CT and MRI
Oh,
for
CT and
clinical
MRI.
evaluation? Yes, yes, sir. Yes.
So, these are the different techniques. Like X-ray, anyone has listened X-ray about the X-ray? When your bone fractures are there, the X-ray has to be done, right? And like B scan, like MRI. So MRI is generally done for this head portion. This is the more extension form of CT scan, right? If you want, because in your head, the small ruptures, small blood clotting has to be measured, right? So this is the fine more details of MRI. So MRI is generally done for the head one. What I know, MRI is more vast form than the CT scan. If it is a big lesion and big hemorrhages can be measured by the CT scan, but the minor details, the minor ruptures has to be done by the MRI. So in CT scan, like 2000 test scans are taken in a minute. In MRI, I think 10,000 or 20,000 scans are taken in a minute in a cycle. So that makes difference from CT scan. But in all things, this X-ray and ultrasound, ultra rays acts.
Okay. So, thank you so much, sir. There is another question. Can we
Yes.
differentiate where there is benign tumor or malignant tumor from the CT scan?
What again, Kapil? Benign and malignant, I'm able to understand.
Yes, sir. How can we differentiate where this is the benign tumor or malignant tumor from the CT scan?
Okay. So benign and malignant cannot be distinguished in a single stand, right? So while doing any patient, you need to start from the history part, right? So you have to take the history since when the mass they have held. Okay. So like since 1 year, 2 year, 3 years. Okay, so the history, first thing in your mind has to be clicked. What is the history the patient is complaining for that mass? Okay, the second thing is the mass is spreading or not. That again come from the history only. Ask the patient, is the size increasing or it is similar like from the beginning only. So the size is increasing or either it is in same in size. So that is the second thing you need to keep in mind. The third thing, like while seeing in the CT scan, is there any calcification is there or not? So these three things, if you combine together, then you can easily identify either it is a benign or a malignant, right? So history is also one of the major important thing to identify it is a benign tumor or a malignant tumor. So if it is spreading in if it is increasing in size and the history is longer and the size is increasing faster and you see the calcification, then you can identify, okay, it is a malignant tumor. But the patient is saying from 10 year, from 15 year, the size is same. The size is not increasing, there is no pain, there is no redness, there is no complaint. So in that cases you can and there is no calcification in CT scan. So in that cases you can think that, okay, it is a benign tumor. Am I clear?
Yes, sir.
Any more questions?
Okay, sir. There is another question from the option. How frequency can CT scan? How frequently can CT scan be done, and why? So what I
So
guess
that
yes,
yes Kapil.
the frequency of CT scan, sir.
Means why the CT has, how frequently the CT scan has to be done, is this the question?
Yeah, yes, sir, yes.
Okay,
I don't know. I'm
so
also clear about this.
okay, this is a very good question. So
Yeah.
how frequently the CT scan has to be done? So see, as you know, as if any one of has done your CT scan or has gone with your attender or with your relative to do for CT scan. CT scan is one of the expensive scans to be done. Okay, and it has while doing CT scan they take consent that it has some side effects also. So like for the pregnant lady it cannot be done, I think everyone knows, right? So it has few side effects also. So while prescribing CT scan, you need to be very clear why you want CT scan to be done. If you think that it is a, if your history and clinical evaluation says that it is a benign tumor, it is not increasing in size, and patient also don't want it to be removed, then why the CT scan has to be done, right? It is from 20 years, the mass is from 20 years, and patient has just come that will this mass will do any other problem in the future or not, only to know that. So in that cases, do you think the CT scan has to be prescribed? No, because CT scan is one of the expensive one. So in only in the cases where you want the surgery to be done, where you think the tumor has been spread till you want to know the extension of the tumors. So in that cases, the CT scan has to be done, and it always has to be done before surgery. And if you and in the if you think the mass is malignant, then after 1 month or 2 months or 3 months of the post surgical thing, you can once you can do so to know that the total mass has been removed or not. And I think that nowadays in the advancement that can easily be known by histopathological lab also. If you keep the mass, right, if you remove the mass and send it to the histopathological lab, so that lab person easily can say that the posterior pole has been removed or not, or some area of the tumor is left in the eye. So they will tell you. So that will also help us to tell that we need to do CT scan again or not. So you need to do CT scan very less. Only in the cases where you think it is very very urgent, in that cases only we need to send for CT scan. Any more question, Kapil?
Okay. Yes, sir. What are the indications for CT scan from the patient part? Thank you, sir. Thank you, sir, for your question.
Okay, so it has two contraindications, systemic and eye also. So in eye, always, because it is a radiation, so it can cause cataract thing, and it can make your vitreous a little bit densified. And while comes to the systemic one, it is totally contraindicated in the pregnant one. Okay, and while doing CT scan, if it is a contrast has to be done. So in contrast, how the contrast is done, a fluid is injected, right? And that, like we do in FFF, fluorescein fundus angiography. So how we inject a dye, in the same way, if you want a contrast image, a dye has to be inserted. So that dye has also again a side effect, systemic side effect, like vomiting, anxiety, and sometimes like in asthma cases, if it has some cardiac problem, it is totally contraindicated. So there are two contraindication in eye separate and systemic separate. So before doing the CT scan, always the radiologist asks this question to the patient, and they tell them to fill the consent, and then only the CT scan is done. Is it clear? Hello, Kapil? Hello?
Yes, yes, sir.
Yeah,
It is clear, sir. Yes, sir. There
any
is
other
another question from the while performing the CT scan.
yes, Kapil, once again.
When should we perform the dynamic imaging while performing this scan? About dynamic, sir.
Yes, again, I'm not able to understand your question.
Yes, sir. When to perform dynamic imaging?
Okay, dynamic imaging.
Sir. Yes,
Okay,
sir.
so dynamic, like dynamic, what is different in dynamic? Like they increase the rate of the scan. Like if it is a 1500 scans in per minute, then they increase little bit more. If you want little finer detail, like in MRI, so if you want little finer details, in that cases MRI has to be done. Generally in the fractures cases, and if you think that there is any injury in the brain, so in that cases the dynamic scan has to be done.
Okay. So I'd like to request all the attendees. Anybody have the question, please unmute your microphone and can ask the question. Okay, sir, I have one query. So, what is the relation between CT scan and ocularist?
Yes.
What is the relation between CT scan and the ocularist?
Okay, so as you know, to be an ocularist, you need to know about the oculoplasty thing, right? Oculoplasty means orbital thing. If you know about the orbit, then only you can be a good ocularist. So sometimes it is a normal cases, right? With the eyeball. Sometimes I have seen in many of the cases, like I have fitted prosthesis like 2 months before, and after 6 months the patient comes that the prosthesis came out. Like prosthesis not fitting well. So in 6 months, I don't think there will be very much difference in the socket. So in that case, what was there was a mass growing inside the orbit, right? And that mass was pushing it, and the mass was slowly increasing in size, so it pushed out, and when it became little bigger, there was no place in the orbit to sit for the prosthesis. So the prosthesis came out. So if you know, so what things you need to explain the patient. why the prosthesis is coming out, right? So in that cases you need to understand the CT scan can be done, and there can be the mass which is pushing out, and the surgical it need to be surgically removed, and after that the prosthesis has to be fitted. So one thing. The second thing, like any patient came to you after enucleation, right? And if it is a retinoblastoma, child is there, and you have fitted the prosthesis, and the patient comes after again 1 year and 2 year and telling that there is pain in the brain, and the baby is falling, being unconscious frequently, sometimes vomiting also. So if they gives like this history, then you need to know that okay, what is retinoblastoma, and how it can regrow. In the retinoblastoma cases, either the enucleation has been done, then also it can grow if few sheets of that tumor has been left in the orbit. So in this way, if you are ocularist, this orbital parts and CT scan can help. So in I generally, being ocularist, when I prescribe, like in the implant cases where enucleation has been done and implant has been placed, and sometimes the implant has been lost, right? Patient comes and, sir, there is no, and while palpating you feel there is no implant, so where the implant has gone? So to check it, where the implant, sometimes I have seen one patient, the implant was totally sitting in the inferior orbit, and it was not palpable at all. So while doing CT scan, we saw that implant is sitting in the inferior orbit, and after that it was removed and a secondary implant was placed. So in this way, it is beneficial for the ocularist, and ocularist also can send the patient to do for CT scan if they feel that the prosthesis is not fitting well, and if you feel that some mass is there, and always can refer oculoplasty surgeon to do the surgeries. So am I able to give your answer, Kapil?
Yes, yes. Sir, if we have to summarize our presentation in summary, so how can we summarize this presentation?
Yes, yes.
If we have to summarize this all presentation as,
okay,
how to explain this?
okay. So in because a CT scan is a vast thing, so if you want to do a summary, always think that CT scan has to be done only in needed cases, and while interpreting a CT scan, you need to compare for the abnormal with the other eyes, and CT scan is generally done while doing the surgery or to see the extent of the tumors, and most of the times it is beneficial or mainly indicated in the malignant tumors. So in short, if we have to say, and there are different I have told you, there are different plane like coronal, axial, and sagittal cuts. So this all comes in the principle. So if you are clear with the principle, if you are clear with the theory of the CT scan, then only you'll be able to interpret the reports.
Okay, sir. Thank you so much, sir, for the informative session, and also
Welcome.
thanks to all the attendees. Yes, sir, attendees for their participation and for their question as well. So I guess we have discussed most of the question. If anybody have any queries, please and can ask.
Any further queries also can be discussed in our group.
Yes, sir. I guess we have almost completed all the question. Okay. Before ending the today's session, I'd like to again express my gratitude towards the presenter and all the attendees. And also, I'd like to appreciate all the helping hands for this iTalks program. Herewith, I am ending the today's session, requesting all of you to drop your review and feedback. So stay safe, stay at home, and keep in touch. Thank you so much. Thank you so much,
Okay,
sir.
thank you, sir. Thank you.